That's exciting. So, are you guys ready for ITT?
Oh.
That's my cheerleader coming at me.
Okay, yeah. Sally will be the cheerleader. So we're back for like a really long session about ITT. And I know they said we don't talk at you for 2 hours, but we do. So we will go till 5 o'clock. So ITT, interdisciplinary training team, Tuesdays, 3 to 5, along with your evaluations in the mornings is ITT. So that's Sally, Lindsay, and I facilitate your group conversation. So ITT, it's the 2 clinical cases that we have already handpicked for you. 2 teams, remember you're broken up into 2 teams, and each team has a leadership team. Everybody, if you're clinical, meets the kiddo, does a presentation to your team. The documentation done by your discipline is the same documentation that you do when you're clinically in your rotation here at Children's. So whatever you normally do, you do. For the ITT cases, the ITT cases for clinical care are all scheduled into Epic, just like any other appointment would be scheduled into Epic, except for we don't drop a charge for you billing folks. You drop a no charge. That's really complicated apparently on the back end. So no, even if you do everything right and you drop the no charge correctly, talk to your supervisor about how you do that. I am not a billing person. I don't understand. All I know is that I clean up the back end with the business directors when the charges get dropped. So if anybody hears from an ITT family that they received a bill, I need to know that, please, so that I can work with our business director teams to clean that up. But work with your supervisor to drop a no charge during your documentation process. Clear to all those folks who do those things. So the ITT cases are patients who are already referred to DDBP. So that's really the main criteria, as you were referred to DDBP. Most of our referrals come from community or internal physicians at the hospital, nurse practitioners, psychologists, school psychologists. When it says schools, it's usually the school psychologist. The types of referrals we receive are listed up there. The most common referral would be rule out autism. That might be because people learned if you put out rule out autism as your reason for referral, you're more likely to get scheduled. Some of the specific diagnoses though, spina bifida, Down syndrome, RTS, certain genetic disorders have special clinics. We'll talk about those in a minute, like dedicated clinics within the division. So those are sometimes also automatic referrals into a specific appointment type. So we were just chatting. This says average number of referrals is 1,000 a month. It's more than that. The number keeps increasing. Our providers aren't increasing at the rate that the numbers are increasing. So right now, in this moment, we have a very large access issue. So technically, the 2 kids who were referred to us, who are coming to us for ITT, were initially told you can't come because we have restrictions on who can come. We'll go through that process in a minute. So the process for referral, we get a referral, it comes to Epic. We have a CSR, customer service rep, who reviews all the referrals. So she's more than just a CSR. She is our only intake person who's reviewing 1,300 referrals a month. It's one lady. And then she is screening them to see if they meet our criteria. Our criteria for coming is ever evolving. So there are certain criteria about where you live and who referred you and how old you are. We'll talk about some of that maybe. It's all up for discussion. So if it's easy, if you live in Avondale, you're referred by PPC, the kids to, and the referral reason is roll out autism. She says, great, let's get you scheduled. Now, how you get scheduled and who you see first could look different. We have different models, but don't worry about that. If it's not an immediate match, it goes on to medical leadership for a review of the referral to make sure, is there anything we're missing? Sometimes it comes to my team to do a little bit more digging or contacting a family or contacting the referring provider to get a little bit more information about what the concern is. And then if we're the right place, and if we're not the right places, it comes to my team to say, like, these are the right places. So DDBP is not the right place. Here are your community providers for certain needs. If it's not a good match and they're not going to be seen in DDBP, it is told to the person who made the referral to us. So if primary care made the referral, it's communicated back to primary care, and it's communicated back the reason the child wanted to be scheduled. So like ITT team 2, that kiddo lives far away, not that far away, but far away. He's outside our primary service area of the hospital, which is Hamilton, Claremont, Warren, Butler, Boone, Kent, and Campbell, and Dearborn counties. He's outside of the counties that touch the hospital. So he was told no, because right now we are limited to our primary service area or new referrals. But then we found out about him, Lindsay talked to mom. She said, sure, yes, we don't mind coming. So we're seeing. So things like that are happening. So when we get a referral, we take it. A scheduler in DDBP, a scheduler calls and leaves a voicemail one time. After that, there's going to be another call, but they're robocalls. You don't know who's calling, and it's just this automated voice that says to call Children's Hospital back at this number. Doesn't say the division, just Children's Hospital. If the child's in school, we love to get copies of like IEPs and ETRs, but that doesn't usually happen. But we like to get them ahead of time. If not, we get releases at times of visits and often request those things. So these are some of those specialty clinics that have some different scheduling rules. Some of us in this room work in spina bifida clinic, and we see anybody, if you have a diagnosis of spina bifida, we don't care where you live, we don't care how old you are, you're going to come to our clinic. We'll see you. So some of those like rules about primary service area and those kinds of things get murky in some of these specialty clinics. So the process for the family varies. So it could be doctor first, then doctor does ordering for testing with speech only, speech and psychology, OT speech and psychology, PT. So all kinds of things. Then you come back to see either the psychologist or the doctor to go over that information sharing session, which we talked about a lot in ITT, because we're going to talk about that a lot in here. Or a child might be scheduled in an arena model where they see multiple people, could be doctor, psychologist, speech, psychologist and speech in one visit, and then come back and have an information sharing session from that. So depending on the age of the child, most of those are rule out autism routes. Depending on the age of the child, who you see can vary. Depending on your insurance, who you see will vary. If you have Kentucky Medicaid, you can't see our psychologist. So we'll take the psychologist part out if there's Kentucky Medicaid as the payer source. And then however the evaluations happened, whatever order they happened in, there will be an information sharing session to go over the results of the evaluation. As we talked about with ITT, it's the same way in DDBP clinic. Usually 99% of the time, it's like doctor or psychologist will do the ISS. Sometimes the nurse practitioners do them, but that would usually be like a kid they have known for a long time. Or they're filling in and they do them in those moments too. Yeah. So this is the process, like each block just is a step in the process. So identify referral and the family questions and concerns based off the referral. Like we get a referral that might just say rule out autism, and that's all we've got. Sometimes that happens. Sometimes we have pages and pages of epic documentation for the past 10 years and have lots of information. So review previous assessments, background information, demographic information for the family. Then in our intake world, determine which teams are needed and possible for assessments. Then the assessments happen. The goal is in our world, the teams can integrate and synthesize the information that we received. In the real world, often that is done by reviewing each other's notes. We don't have the access and time to be talking face to face and having these discussions about every patient that we're seeing when we're seeing a lot of patients. Ideally, we could do this for everybody. We will work together on diagnosis, etiology. We'll talk about DSM things. We'll talk about what needs to go where. And we'll also identify if we need more testing. So we might come out during our ITT meetings and say, this is all really great, but like this kid really needs to go to ENT. That happened last year. This kid really needs to see genetics. And then it wasn't just genetics. They need to see this specific clinic in genetics. And then we help facilitate those referrals to make sure they get that whole medical picture if we're missing anything. Develop plans, recommendations, including community resources for the child and for the family, and how to support the whole family. Cool. And that's where the ISS part happens. So there was a reading. This part kind of links back to the reading. That the interdisciplinary assessment process itself is an intervention. So just some of these things I've kept for many years. So these two families, if you looked at their schedules, they're about to come see us like a lot in a very short period of time. At many appointments, we ask many similar questions. Maybe we don't ask the same questions, but they're similar. But we're probably asking them for not necessarily always the same reason. From your discipline, you're trying to gather information because it helps you determine which assessment to use or which tools to use, but somebody else is using that information to create a history to know if I should refer to anyone else and what that would look like. So we ask a lot of the same questions. So the families are hearing the same things frequently. So we might have conversations about, well, at my visit, mom gave this answer to this question. And a month later, we're like, well, now mom's saying this. And those two things are really different. But she's also met with multiple people in the meantime and maybe has changed some practices at home. We've had families go from there's 0 sleep concerns to this kid's not sleeping at all. And I was like, well, maybe is it the way you're asking the question, or is someone now paying more attention to sleep patterns or paying more attention to like, well, my kid only sleeps when they're in bed with me. They won't sleep in their own bed. And then as we ask things, families might start changing some of their behavior and then seeing some different things at home because we keep asking about it. So each time we meet with the family, it is an intervention, and they might change their behavior or they might not, or the kid might get really comfortable. This happens a lot. The first visit's fine and the kid does great. By the last visit, the kid is like out of control because now they're really comfortable being here and seeing all of us. So we get like last year, we had a kid who was totally different from visit 1 to the last visit. Totally different. But he also got really comfortable with our building, all of our equipment, checking out the laptops and all the extra stuff I make you guys put through. So those things kind of happen over time. So we have to keep that in mind. And then we're asking about strengths and the challenges. So parents might start changing how they talk about strengths or challenges that they're experiencing. And then it's really hard for all of us to like not give some feedback, right? Like that's part of what we do. We're used to at the end, especially at the end of sessions or visits, giving some feedback about, you said this was a problem. I don't want to make you sit on your problem for the next 4 weeks while we all talk about it. So tend to say, here's some solutions, here's some things to try. You're really struggling with sleep. Let's try this. Here's some ideas. And so when you come back in a week, we get some different information too. And then they might also copy us. So we tend to role model the kind of positive reinforcement that we're hoping families will go home and take into their homes. So sometimes families start role modeling what they see us doing, especially if it is helping or working. So hopefully they take some good pieces away from just observing us interact with their child. Okay. Important things about ITT. If you are clinical, you will meet with this child and on a schedule that was sent to you until there's a change. So, and there will be a change. So keep me posted. If you are sick, if you're not going to make it to your day where you are scheduled to meet with this child, let me know. It will rain. 75 will be a mess. People are going to run late. Families will run late. They will be told. They know to contact us. And then we'll try to communicate it out to everyone seeing them. Sometimes they just decide they don't want to participate. And then we find new people. Every clinical discipline will present. So if you see this child or family, you will be presenting to your ITT team on the schedule that's outlined in 2 places on campus, including today. And then each team will do that case conference meeting to how to we share the results with the family. No patient names go on campus. So we said you have to create like a visual representation for your presentation. It can be PowerPoint, it can be Canva, you can be creative, but we need something up here to like follow along. Don't put the child's names, use initials on Canvas. But when we're meeting, you can call them Sincere and Vincent. That's their names. We can use their first names while we're meeting. But don't type them on Canvas, please. So the ITT meetings, before your meetings on Tuesdays, there will be an agenda that goes up on Canvas. Work with your leadership team. You're going to get an email saying, how much time do you need to do your presentation? If it's your week to present, work with your leadership team to make sure we can try to accommodate how much time you would like to present. You may not get as much time as you ask for, depending on the number of people presenting. So you're going to work on your presentation with your clinical supervisor so that we can get all the information in and get out of here on time. So time is limited. It's on the agenda. We're sharing information, not our recommendations. So what happened? What tools did you use? We're going to go into a whole, Sally goes into a whole thing here. We want to know what tools you use. Why do you pick the tools that you use? Is it an age thing? Is it something the child said? Is it something you already learned from somebody else who's already met with the child? How did you select what you used? And then how did it go? What did you see? What were your concerns? What were your scores in table format? Let's like make it visually appealing somehow so we can follow your scores. And non-clinical trainees, you absolutely have a role in ITT. Ask us questions, make sure people are clarifying. Why did you do that? Why don't you do this? How did you know to use this information? How did you know that this would be the next step? Like just keep asking questions. We're also here to understand, like I said, this is the ideal situation for how we would see every patient. We'd be able to talk to everybody who did the evaluations and work together. That's not really what happens. So what we need to know is, even in my, I guess in clinical, my non-provider role, I have a family on the phone who has all these questions and my kid's doing all these things. I'm going, oh, it sounds like maybe you need to see a provider to talk about a speech referral, because what you're talking about is speech. But I learned a lot about what speech therapists do by sitting here for many years and learning about what y'all do. And so social skills and all those conversations. And so it's understanding what your peers are doing and what they do and how they would support a child you're seeing when you don't have the luxury of this, or you're at a school and you're like, I think there's something really going on. Who would I refer to? That's not my discipline to figure that out. So we're going to learn a lot from each other. Sally and I always say we learn something new all the time, almost every ITT session. This is back to that. You've already seen a lot of this. So we want a visual. It doesn't have to be any certain number of slides. We're not saying it's a specific amount of time. We want something to help us follow along with your presentation. It's going to be posted to Canva or to Canvas, which is helpful for the rest of your team. So if they've missed the session, they've got something to refer back to. And then we'll use that information to help us with the ISS as well. I'm done. This is not
You're tagging out.
not my girl.
Okay, we're going to spend some time talking about what a standardized test is. When the clinicians go in to meet with a family, they're going to do a history. There might be some standard exam things that they do. This is above and beyond those things, a standardized test. One thing I did want to mention about the history, because Marta touched on this, we have sometimes gotten feedback from families that they are tired of getting the same question every time they come in. Like, are you guys not talking to each other? And that also happens in the big system of children's, because families know that we can all look in Epic and see information. And so, don't you know this about my kid already, kind of thing. I think one nice way to approach that is when you sit down with a family and ask and start your history, you can share the things you already know or have learned, either from your chart review or from your time in ITT, and can follow up with questions that might be more specific to your discipline to give you more information, and or for mom to say, or dad or grandma, whoever brings them, this is not actually correct information, or we've changed that in the last month. So that's just a good sort of practice in general. But typically for these DDBP evaluations, we are being asked to do a standardized test most of the time to determine where those child's abilities fall on a norm reference scale. So a standardized test is administered and scored in a consistent manner. It's typically a published test. It has a specific purpose. It has been validated on a specific population of children and for specific age groups. So the test you see down here at the bottom is the Peabody, which is a very common OT and physical therapy test. It only goes up to like 5.5 years of age. And we would then have to use a different test to look at gross motor skills above that age group. There is a instruction book for how to administer. There are specific instructions for every test item. In some of the tests, we may only be able to give verbal instructions. We may not be able to give them a demonstration of what we're asking them to do. And for kids who have more visual learning strengths, that might be an issue, right? To just hear a command about what we want them to do and not kind of see what it is. So standardized tests are very specific, and each of the disciplines have tests that they use. We're in a really unique setting too, because most of your departments have every test that's been standardized and is validated and reliable. And a lot of the community organizations are not going to have access because those are expensive. That one test here that I was showing you runs about $1,500. Each one of the satellites that has OT and PT has that test. And then we have to buy the booklets. You cannot copy the booklets forward. So there's an ongoing test kind of cost to maintain those. And so like understanding that there might be 5 tests on the market that provide information about a certain motor skill, whether it's fine motor or gross motor or oral motor, speech and language, but there might be better tests or tests that were validated, or the reliability was done on a bigger population or a more diverse population. And so those are all really important things to keep in mind. There are several different purposes of a standardized test. So one can be for screening and diagnostic purposes. The other is to gather information and determine a baseline. We often use them to determine eligibility for services. So when we look at the standard deviation or the difference of that child's score from the norm or that bell curve, which we're going to review in a minute, typically school systems will say if their skills are plus or minus minus 1.5 or 2 standard deviations below the mean, they might qualify for services. So sometimes that score matters in terms of if they are eligible for services, and also for planning interventions. So when I do a test and maybe the max score on any item is a 2, if there are items that the child scores a 0 or a 1 on, those might become my goals for therapy, right? Because I know those are things that a typically developing child would be doing at their age, and those are places that we can build on. Those first like 4 categories are typically what we call norm reference tests. So basically, they are tests that compare the child's performance with a normed reference sample of children. Other ways in which standardized testing is used is to document progress. So those are more outcome measures. They're usually criterion reference. They're not norm reference tests, used for like discharge planning and other outcome measures. Things like the 6-minute walk test is an example of an outcome measure. The thing to keep in mind is that we are often coming at these evaluations asking about things that the child isn't doing well or parents are concerned about. It's really important to think about a strength-based model of asking parents, what are you proud about your child being able to do? What strengths do you see in your child? Those are also things we can build upon, right? So it's really helpful to make sure that we give them opportunities, especially in the beginning, to say, brag about your kid. What things are they doing well? And the other thing I wanted to point out is that if we think about looking at the child holistically, using the ICF model is a really good way to do that. So the International Classification of Function, Disability, and Health. And the health condition itself, say like a condition like Down syndrome might be at the top, but then you've got different categories in the middle: body function and structures impairment. So things like range of motion, strength, blood pressure, heart rate, those would be in that category. Activity would be things that they can do. So typically motor skills. And participation are motor skills in a community environment. So I can run. Participation is I can run on a track team, or I can use that running skill in a soccer game. A lot of our tested measures and our standardized tests really look at body function and structure limitations and activity limitations. And we really need to be thinking about participation. Why does this matter? Okay, the kid has flat feet. How does that impact their daily life and their ability to function within their peer group and their family? And so making sure that we're making recommendations on things that are relatively going to change the child's function or prevent an issue later on. And then all the time, keeping in mind those environmental and personal factors we call contextual factors. And that's where the family advocates and the social workers and the psychologists are really going to bring our attention to what are the other demands on this family? What are their goals and priorities? Where do they have resources? Where are some of the resources limiting their choices about seeking interventions? And so in ITT, I think we do a really nice job of looking at everything globally and holistically, but also just keep in mind that we're really looking at like participation activity. Okay, so don't groan. I know this probably brings back like a few increased heart rate for a minute, but when we talk about norm reference tests, we're really talking about a bell curve. And the reason to bring this up is when clinicians get up and give their presentations about the things that they saw and sort of what those scores were, others of us who are not in your discipline or non-clinical folks really need to understand what you're talking about when you're talking about the scores. The other thing I will share with you is that there's a number of tests. I know more about the OT-PT world, but I've also seen it in some of the other disciplines where they don't even talk about a score, but the result is the child is moderately impaired in this area, or minimally impaired in this area, or more like others, or just like the majority of others. And it's like, well, what does that mean? All of those things can be routed back to a standard deviation if you look in their test manual. And sometimes the verbiage they use for the degree of impairment doesn't match up, right? There's two standard deviations below the mean, which is very delayed. And they're talking about it being moderate impairment or minimally impaired. So I don't know. This is whoa, that was a bad choice. Is there what am I trying to say? Clicky thing? Yes, a clicky thing, or the laser light. Oh, pointer. All right, I'll just move. Can you guys still hear me? There's some folks on.
It doesn't come out like
Soon.
Bob Barker. I thought it.
Yeah, it's all good. So basically we're talking about the bell-shaped curve. Obviously in the middle is called the median, right? And then on either side, so the majority of kids are going to fall in that plus or minus 1 standard deviation. So you see how short the curve gets on the end ranges. So this is 1 standard deviation above, 1 standard deviation below. But what you can see is that these all line up to percentiles, right? And oftentimes these standard deviations are referred to as Z-scores. A lot of times we talk to families about a percentile or an age equivalent. And I want to share with you why that's not always the best way. Sometimes parents understand it a little better, but it's not always the best way for us to be thinking about what the child's actual performance is. So the mean is dead in the middle, and we'll dig into that a little further. Typically, when you're doing these standardized tests that are norm referenced, you're going to have a raw score for individual sections of the test, And that raw score will be converted, if you're lucky, through a computer program that you plug numbers into. That's rare, but coming for some. Most of the time, it's a booklet where the Brad's shaking his head, where you have to open the book and you have to do all of this and make sure you have a piece of paper so you don't do like me and jump forward and get the answers wrong. But basically, it will correlate, the raw score for the child's age will correlate to an age equivalent, a percentile, and a standard score. If you all think back to some of the tests you took in school, math tests, reading tests, and you would get a brochure like this in the mail to your parents that said, Sarah scored in the such and such percentile for her age, right? And they'd even give you like an age equivalent. So the issue is that an age equivalent, so let's say that someone is 4 years old, and for the motor skills related to standing and balance, shared that their age equivalent is 2 years of age, right? What that means is that 50% of children who are 2 years of age demonstrate that skill or would get that same score on the test. But remember, for 2 years of age children, they also have a bell curve of skills. Some kids who are 2 years of age are going to be performing less well than the median. Some of those kids who are 2 years of age are going to be performing better than the median. And so there's a range of skill development. But in our mind's eye, if I tell you a 4-year-old looks like a 2-year-old to me in terms of their motor skills, you can sort of think about what that might mean, right? The same is true for like percentiles typically. So the age equivalent skills are calculated from the average score. And for example, if 50% of 6-year-olds, if the score for that section is 40, then any child who scores 40 would have an age equivalent of 6 years. It doesn't matter if they're 8 or 10 or 4, right? They could be a 4-year-old and they're performing like a 6-year-old. Parents often want to know what the age equivalents are, but it's really important to share with them that that's only like 50% of 6-year-olds in this example that can perform that skill at that level. Age equivalents are not normally distributed. It is simply the score that 50% of children at that age achieve that score, right? So percentiles and standard scores are normally distributed, but age equivalents are not necessarily. So a percentile is the number of children of the same age that scored lower or equal. So an idea is that if Angie scored in the 70th percentile, she scored better than or equal to 70% of her age matched peers. And it's important to say that whole thing, right? So we're talking about how she compares to kids her same age. Standard scores are that deviation from the mean, the bell-shaped curve. So typically it's a Z-score, but I will tell you some tests use different language in terms of what that standard deviation score is. And so it's not always called a Z-score, and that makes things confusing. So if she scored plus 0.5 standard deviations, she scored 5 standard deviations, 0.5 standard deviations above the mean. So what that looks like is 0.5 standard deviations above the mean is sort of here. And, you know, if we talk about Z-scores, this is, like I said, -1 standard deviation below the mean. This is average and this is above. But it's really, you can see that this group of kids that are 2 standard deviations above and below the mean are outliers, right? It's a smaller group, but they certainly are seen as kind of outliers in terms of their skill development. Anybody have a question so far? This all seem like review? Sort of, kind of. All right, so what I wanted to show you on this slide is really that when you plot a score on a bell-shaped curve, it all lines up, except for age equivalents, that might not. But like the percentile and the standard deviation should line up with each other. So basically on this one at minus 1.5 standard deviations below the mean, there is a cumulative percentage, and I'm having a hard time reading that across the room, of like 7% basically. And so what we really want you guys to do when you're talking about performance and scores is to bring it back to those Z-scores, those standard deviations from the mean. It's even helpful if at the end of your section of a test, you sort of put stars on the bell-shaped curve to kind of show us where they are performing. It gives us a better like overall view. What we would ask is that you avoid sharing only the test language if it says things like moderately impaired or not like others. We don't know what that means, right? But these scores we do understand better. Another couple of things that we need to think about when we're choosing a standardized test is the reliability and validity. So reliability is the ability to produce consistent, repeatable results. And there's two different types. So whether different clinicians performing the same test are all reliable within each other versus whether the test itself performs reliably. Validity is if it's measuring what it's supposed to measure. And typically validity is established by looking at that test against some gold standard. And sometimes there's not a gold standard for that test. If you look at sort of the targets below, which one of these examples would demonstrate a test that is reliable? It's consistently and repeated, it has consistent repeatable results. Say that loud, Taylor.
One on the right and the one on the.
So the far one on the left and the far one on the right, right? They're getting similar results every single time, right? So they're both reliable, but are they both hitting the target? No, only one of them is reliable and valid. So it's measuring what you want to. The one in the middle is not reliable or valid. The one on the right is reliable, but not valid. Okay. Those are all things that if you open up the test booklet, it will give you information about the reliability and validity testing that was done. Sometimes it matters if the test was validated on a certain diagnosis or not. There are tests in PT that we only use for a certain diagnosis because that's what they were validated on. That's what the test was designed to be used for. So when you're choosing a test, you want to keep in mind the psychometric properties, the purpose for which it was designed, the sample used for norms. So another example is the Denver is a questionnaire that looks at motor skill development. It's a screening tool, but it was validated on a very small population of kids. And I'm off the top of my head, I would say like 1,500. Ages and Stages is a much newer test. It goes up to a higher age range, and it was validated on something like more than 10,000 children, right? So it's a newer test. The validation work was done on a much bigger, more diverse population, and so we feel like it's a more robust test. You need to look at the age ranges for the test, strengths and weaknesses. This has come up before where folks in the room have asked the question of, you're using a test that requires verbal skills on a child who's nonverbal. And the clinician has had to share, that's an excellent insight. We don't have a better test, right? And so just reporting the test results is only part of the story. Sharing the limitations of the test is also part of that story. And if there is a better test to use with that child with their skill set, then we should be doing that, right? And so other considerations could be the time available, the setting, the child's ability to follow commands and their behavior, and the cost to administer, which we've talked about a little bit before. Patient factors that go into account are, again, the child's age, their mobility and functional level, those cognitive and language abilities, as well as behavior. And Marta already shared that we want you to talk about what their behavior was like in that testing environment. If there are things that you have to change about the test or how you administer it, those things need to be noted. And so the questions that you want to answer are, what developmental or functional areas need to be examined? Why was the child referred? Do they have an existing diagnosis? And what is the caregiver or referral source concerned about? Test modifications. So a standardized test typically comes with a number of very specific directions about how to perform. For example, in the Peabody, you get 2 trials. A lot of times it's a verbal commands. In some cases, you can give them a visual cue, or you can demonstrate the skill. But if you give them 5 trials, which is very common with if you're doing a test for the first time, because as a clinician, you're like, well, maybe I didn't do that right. Let's give them the benefit of the doubt. What can happen if the test calls for 2 trials and you give them 5? What is the name for that? What can happen as a result of giving them more chances? Yeah, there's practice effects, right? So they're getting to practice more and might score better because you're giving them more time. Things like changing the sequence. If there's a specific sequence you have to follow, if you change that sequence, it can modify the test. Excluding items, asking parents to say, you know, I don't see this skill today. Can you tell me how they do this at school and score, or at home, and scoring that? Most tests do not allow that. Some tests do. Allowing extra time, modifying the materials or the equipment, using a bench that's not tall enough for that item could change how well they do with a test item. Estimating or assuming the score, or using it for a purpose other than it was developed for. The problem with that is if you modify the standard test, then you cannot use those results to compare against the norm reference sample. There's been errors in how you've collected those results, so it limits your ability then to interpret the scores against a norm reference sample, okay? And then by default, it alters the reliability and validity of the test. But performing these tests takes time and skill, right? So those of you who are clinicians will have a clinical supervisor with you. They might ask you to take the test booklet home and practice items of the test if you haven't done it before. And so there is a psychomotor skill to learning how to give some of these tests as well. So for the ITT case conference, do you want to do this part? Okay,
I feel like we're repetitive. Okay,
a little bit.
so, and might be slightly out of order. So we have one meeting dedicated to the case conference. So the other meetings, when we meet, there's a lot of that stuff. What Sally just did. Not all the disciplines who present have standardized assessments and standard scores and are going to do all of those pieces. So any of you who are nervous, this may not apply to you, and that's okay. So, and then we have the ITT case conference where we've already heard all of that information from the clinical trainees. And now we spend this meeting really going over what are the appropriate diagnoses? What are the next steps? Really, what are the next steps? What are the recommendations? How does the family implement those recommendations? Are those recommendations and diagnoses in alignment with what the family thinks is happening? And then how do we prepare ourselves for how the family might respond to the information we're sharing? And we make sure we know who's going to be there for the information sharing session and what the follow-up plan is, whether that kid comes back to DDBP or not. So we'll also have a lot of that discussion as well. I know not everyone is housed in DDBP. So if you have DDBP questions or questions about how we selected the cases, like, you're welcome to ask at any point now or at any other point about general questions about DDBP as well. Even if you are housed here, it's complicated. The hospital's really complicated. Yeah.
The family. So when you're doing the testing, are the families in the room? Because a lot of times Joe was taken away from me to be tested and I was in the waiting room. So everyone's together for the testing?
It depends on the discipline and the test.
Okay. So that can vary.
It's a great question.
And that might vary from ITT cases this semester and next semester too. The ages of the kids is also going to change.
Probably a big thing too, right?
Some of it's the age, some of it's the child, and some of it's the testing and the discipline. Sometimes it's people like us who say, hey, can we sneak mom out and just talk to mom for a minute?
So if I'm in family discipline though, would I ever be able to just sit with them in the waiting room? Because I mean, sometimes that gets very tedious and long just to sit and wait while you're all in there doing the testing.
Usually in ITT, the family is not just sitting in the waiting room.
They're not.
Partly because I think I have slides on this. I don't know. There's a lot of slides.
I just was curious for my own experience.
Partly because ITT is different.
I've never.
So if these families the process is going to feel different to them. It does look different. The reality is this is different than just coming through DDBP. Some of that is like when you're the clinical person, you're going to be responsible for getting a Lend laptop out of the Lend lounge, setting it up. There's a Zoom meeting going where people can watch you do your evaluations live. And we will record them. They will get uploaded for future viewing from your other trainee friends. So it's different from the get-go. Everything is different about it. So you could observe and observations across discipline assignment. One of the options is observing a ITT case and doing one of your observations across disciplines that way. You can watch it on Zoom. You can watch your case. So family training and social work, sometimes we do watch more of the evaluations throughout the semester live while they're happening. So the way that it looks is different. And it's also often the family's not meeting with one discipline. So the day, I don't remember if you're team 1 or team 2, but like that day, I think the family's meeting with 4 people. So mom's like never gonna be alone because psychology takes a long time. So usually like you might meet with mom during that evaluation if there's a part for mom to step away, those kinds of things. So it's different than regular DDBP eval visits.
But that's a lovely sentiment.
Yes.
And if you find opportunities, I'm sure you can talk with Elizabeth about whether there's opportunities.
You have to like pack snacks to come to an appointment.
Yes, you do. Yeah. These are long days. Yeah.
So you mentioned that people could like watch us do our evaluation. So in that case, I know we also have to do like a case where like a family advocate kind of watches us and like tells us feedback. Does this count in that scenario?
Elizabeth, does this count? Can this be a viewing for family-centered care?
Yes.
Yes.
I think the biggest piece about that is that you get feedback from the person about your performance. And in person is just a little nicer, but if you need to do it that other way, or they have trouble scheduling coming to your session, that has happened in the past where they watch the recorded.
Or they might come to your ITT. Like if that's what you want, they can come to your ITT.
Right.
Just talk to Elizabeth and they'll get that all scheduled.
Yeah, so last year, we decided on the ITT and the family discipline training is there too. So it's a nice addition.
Yeah.
Please don't want to overwhelm the family with too many people.
Yeah. We try to prepare them that there's like a lot of people in and out, and we try to prepare them. But so we also prepare the family, like this is a little bit of a different experience on their end as well. So, yes. So the case conference sheet, our note taker is going to use this at each of our meetings. This is where minutes are going to be taken. It will be uploaded to Canvas. You can always review it, especially after you present. If you've got any edits to what you presented, please just fix it to help your note taker and the team keep moving. So I've talked about these things. There's an ISS. This semester it's being led by psychology. They're both scheduled into Lindsay's schedule. They're already there. So the psychologist who's doing the evaluation will lead the ISS. The case conference meeting will decide who else is there. Oh my gosh. Okay. I already said these things too. Okay. So things to keep into consideration is like emotional readiness for information. So the ISS can be hard. For some families, it's a relief. And throughout the process, we'll probably get an idea of where we're headed in that direction. And families often take what the professionals have to say very seriously. So keep that in mind. We'll be strengths-based. Part of our case conference is highlighting the strengths. So what were the strengths of this child and this family through this process? What did we see? And we will make sure they have written materials, not just the evaluations. We also work to make sure they have written materials to help them with those next steps, in the execution of next steps. Okay. Any questions about ITT meetings, presenting, and the ISS? My goodness, maybe we need to like cut back some more slides.
Yeah.
Okay, We've talked about a lot of these things already. But some people in the room, our family trainees, have had this experience. You've brought your child for these evaluations. You come with feeling. And we hear from families all the time what the experience is like, the positives and the negatives. So keeping that in mind, like, what would this feel like? The families also are aware that they're meeting with trainees. They know that's happening. So they're prepared for trainees with supervisors, and that means more people also. But families might also have some preconceived notions about meeting with somebody who's the trainee. So keeping that in mind. And also our prior experiences. Our one guy hasn't had very much care at Children's. Team 1, he's been here a lot. So they have a whole preconceived notion about what Children's is, how they get treated at Children's, and expectations around Children's. There are different expectations in different areas, different care provided in different areas. We'll see if social work lets her down. She's used to having a lot of social work support. She'll just go back to her care manager, it's fine. And understanding, like, who are all of us? What is our job? What is our role? We're really confusing. Even if we go in the room and say, this is my name, this is my role, that's great, but like, what does that mean? So it can be really confusing about who we all are. Parents might be anxious. Usually they are. We ask a lot of questions. Also, yeah.
You're talking, maybe not to put too much of my own in there too, and like, just remembering that it's an actual child, because I was in neurology quite a lot, and it's like super smart people, and it was like, he was data, and sometimes it have to be too. And like, just that is important, that they're just affiliated.
Yes, so this is a child, so we often say, like, this is your child first, then these are the other pieces to this. And we're all just have our spot. So what are we trying to figure out? What are we trying to learn from your child? In my world, I'm like, what am I trying to learn from the parent? Most of my interactions with the parent.
Please keep telling us.
Yes,
your own
yes,
experience.
Yes, that's your role here.
But like, our main neurologist went off to like head research, which made perfect sense, because she like, could he come every week? And I'm like, not come every week, but it does, that is just important, because to the parent, you still have to go home and bathe them and do all that other stuff. So.
Julie, those pieces of feedback are super important for all of us to hear, right? And so keep doing that, and keep doing that throughout the semester. No, you're not at all. We're encouraging you.
No.
Keep doing it. This is how we learn as clinicians. We really need that feedback about what it's like for families. That's how we grow. And so we're really glad that you're sharing.
Okay. So consent to treat is determined at registration here at Children's. So these things are like children specific. That Children's at registration, they say, are you able to consent to treat? If the person says yes, we say, great, we're happy to see you. No further questions are asked. That's not like real life. So if a child needs like surgery or blood transfusion, something more invasive, that doesn't fly. But for what we're doing, and what most of you guys are going to do in your regular clinical practice, the question is, can you consent to treat? Yes, please sign here. Okay. We don't ask any more questions. Now, that becomes a problem when I say, but can I talk to his school and get a copy of your child's IEP? I need to know that the person who's signing that form truly has custody or guardianship of this child. So that may not be the person at the front who said, I'm grandma, sure, I have consent to treat, and signed. Grandma can't sign my form unless she's the legal guardian. So consent to treat and releasing of information are different. If you have questions about consent to treat with our ITT patients, let me know, but both these parents pretty much have already given us consent to treat, even though for one of our cases, we might not always see a parent. We likely are going to see a grandparent. But mom worked that out in her schedule, so she wants grandma to come. For release of information, if we want to talk to someone outside of Children's Hospital, we need a release of information form signed by a legal guardian. In this case, for ITT purposes, we are lucky that we picked 2 kids who have parents as legal guardians. It gets more complicated in other situations. And then we'll also identify specific team members who are going to act on those releases of information. Usually it's school related, usually it's social work. Who does the reaching out to like the community people, school, DD services, those kinds of things. It's usually, you guys might get the release for us during your visit, but then we take it from there and we'll connect to those community partners. But we'll talk about that in our ITT meetings. So you'll all be prepared. Okay.
Unless you wanna like have a little bit of a happier way to end.
I mean, currently the ending is like a downer.
Yeah.
Are we gonna be able to do like a chart review on each of these patients before they come?
You'll have the med rec numbers, so you'll be able to do that.
Okay.
One child has a lot of information, one child has none.
Because this is on Canvas, don't have them typed into here, but in my backpack, I have full names and MRNs. Yes, and then you can like see all of their appointments in it.
So those at the very end.
Yes. Okay, we'll come back. And then we're gonna like, real quick, slide in this like Debbie Downer conversation. Because this is one of the rare times I just have a lot of time. So I'm social work, so we can talk about abuse and neglect too. So this is, when I'm gonna talk about abuse and neglect, I'm gonna talk about it from the perspective of you being in a children's hospital facility. When you are out in your world working, you probably want to check in about who are your people, who do you go to? If you're sitting in a school and a child discloses something that's going on at home, who do you talk to? How do you get a hold of them? And how do you get a hold of them right away? Pretty much everyone, every clinical person here is a mandated reporter. So if a child discloses abuse and you don't do anything, that's a problem. If you're a mandated reporter. Sometimes it seemed okay in the minute, but then I slept on it and now I don't feel so good about it. So I often get calls like the next day. That's more complicated. So we want to deal with our concerns in the moment if we have abuse, neglect. And then I'm going to go ahead and throw in the half of the psychosocial bundle. Help me, because I don't know it as well as you do, probably. If you have concern that the child is, if you have suicidal concern, we have a plan for that. If you have concern that the child is being trafficked, there's an assessment for that too. So those are abuse, neglect, human trafficking, and suicide, all things you should contact, if you're a children's, a social worker about before they leave. Homicide, yeah. Goes with the suicide. Most of our kids don't have homicidal intent. In DWP, to be honest, these suicide, homicide, and trafficking things don't come up very often, so I have to go get a job aid to remember how to do that. So I did put, Sally found a very lovely child abuse fact sheet, which is also up on Canvas today. This is the definition of abuse. So any recent act or failure on the part of a parent or caretaker, which results in the death, serious physical or emotional harm, sexual abuse, or exploitation, or this is dependency, a failure to act, which presents imminent risk of serious harm. So I bolded some words because when you call children's services, they say things like, so will the kid die? Or is there serious irrevocable harm that may happen? Those are like their threshold. So, and child caretaker, child typically it's a person under the age of 18. That gets complicated in our population because certain jurisdictions will listen to us if a child is a patient who is 22 but has an intellectual disability. In some states, Indiana, at 18, you call adult protective services. And guess what? They don't do anything. So these are the definitions of physical abuse, sexual abuse, exploitation, emotional treatment, and neglect. Physical abuse, it has to leave a mark. You can hit a child. You can hit a child with a thing as long as you don't leave a mark in the act of doing that. Again, the mark has to last too. So a mark that stays there and needs proof that it was present. is taken into an investigation. Our job is to report, not to investigate. We report concerns. The Child Protective Service body for the jurisdiction that the abuse happened in is responsible for the investigation or not. Sexual abuse, pretty obvious. Emotional maltreatment is really hard to prove, investigate, and nearly impossible to get it investigated unless there's something else going on along with it. And neglect is the failure to do something. So honestly, around here, the most neglectful thing we get is educational neglect. You have to children in the United States have to be enrolled in school. You have to. It can be homeschool, it can be virtual school, it can be your neighborhood school, but like you have to enroll in school and you have to tell your school district what you're doing. And dependency is when your omission is putting the child in danger. So dependency can be things like living with a drug dealer, a known drug dealer. You're not hurting the child, but you're leaving the child in an unsafe condition. It's also hard to get a dependency case investigated. So mandated reporter, nearly everyone with a license is responsible. You're a mandated reporter, you have to report. Anyone can report concerns. So like you witness something on the street, you can call and make a report concerns. These are like the common around here things we're going to refer to. In Ohio, it's Job and Family Services. We call it JFS. They're the reporting body. They also are like where you get your food stamps, your Medicaid, and they do all those things. So we also often will say, have you contacted JFS? In Ohio, it's the county where the child resides. It gets complicated, like if parents live in different counties, so you can call a social worker. The rule of thumb at the hospital is you should call a social worker in the moment when you're having concerns about abuse and neglect prior to the family leaving. So then we come and we ask the questions, and you don't have to. We do. We document it. We make the report. And then each county is very different. What they investigate is different. When you can call them is different. When the police come is different. Kentucky, it's one hotline. It's a centralized hotline that you can call, email, or fax your concerns to. They give you the options of emailing and faxing your concerns because you wait on hold so long. So that's Kentucky. No matter what time of day you call, there's always a hold. Indiana, it's also a one contact number for the state. They answer the phone from there. But then in Kentucky, we call it the cabinet. In Indiana, it's DCS, Department of Children's Services. And then we'll also often say like CPS, which isn't Cincinnati Public Schools, but sometimes it is, but sometimes we mean Child Protective Services. So if you don't know, like the abbreviation, just speak up to whoever you're working with. So making the report, I just focused it on Hamilton County. You call 241-KIDS 5437. You listen to a lot of spiel. They say a lot, I don't remember, but there's a lot of stuff said. These are the things they're going to ask. They need to know who the kid is, how old the kid is, date of birth. They need mom's name, if at all possible, because they file under mom's name. So when they're on their system, when they plug in mom's name, they can see all the previous reports on multiple children if they had that mom. So that helps, especially in situations where people are calling frequently, trying to make a case, to try to get someone to investigate. Having a consistent mom name helps their system. They need to know the age of the child. In our world, if we know the child has an intellectual disability, developmental disability, if they have autism, if they're nonverbal, if they have Down syndrome, if they have medical needs, if they require intermittent cathing, if that medication requires being in a refrigerator, letting them know they are not medical. They know zero things about medical, and medical tends to scare them. So they need us to help them understand this needs to happen on this increment. And it's not. So they need and they also, if we know this child, we just did these evaluations, this child is nonverbal and they have an IQ at this, so I know that it says he's 8 years old. They like, but what does he function like? That helps them on the other end. Can he call for help? So this is a 16-year-old. He's fine. He can call for help. No, he can't because of these things. So that helps makes them understand what we're dealing with. They need to know the address of where they're going. Because if they investigate, they're going to go knock on a door. So they need to know where to go. And then they need to know who will be there. Children, Hamilton County also always asks, this is not on the slide, are there dogs and are there weapons? That also can pertain to like who all is going to go out to knock on the door. And the name of the person that we are concerned about. So educational neglect, parent, sexual abuse, mom said, the neighbor, his name, if we can get mom to give us his name, that's super helpful, those kinds of things. And then any other information. And like, what were we told? So the reason it's important that the person who's making the phone call makes the report is all they care about is what was I told? So when I call and I say, well, they met with Lindsay earlier this morning and mom said to Lindsay, XYZ, they're like, that's nice. That's third-hand information. Have Lindsay call us back together. Sometimes we do that, like let's call together, or they just won't take it. It'll be immediately screened out. So they need to hear what I heard. So in Ohio, we call in the report's reviewed by the intake team at Hamilton County. It's an intake team at 241 Kids, staffed 24 hours a day, 7 days a week, 365 days a year. There's a person who answers the phone. Usually they say, here's your case number. I'm going to staff it, which means it gets reviewed with a manager. You then should be notified, but you're not. You're supposed to be notified in writing if your staffing was closed, but with your case number, you can call back later and ask. Or it can be assigned to an investigator. So that's the go knock on the door. That person's probably not a social worker, but in the movies, they all say they're social workers and they're not. They're not licensed and they typically don't have degrees in social work. If they do, they don't stay in that job very long. At that point, an investigation is only supposed to last 30 days. They're really behind in paperwork. You might find out they're open for 6 months. That's not supposed to happen, but it can. And then the investigator decides what happens next. Do we go to court? The social worker, there's no social worker, JFS does not say this kid leaves. In an emergency, they can take a child out briefly. That's a decision made by the courts. So then they go to court. So if they knock on a door in the middle of the night, there's no adults home and there's kids running wild and there's unsafe conditions, they can take those kids down to the JFS building for the night. And they go to court in the morning to have her judge decide where those kids go. And the investigation determines if abuse or neglect is happening. There's many options. There's many things that happen. But juvenile court, criminal court could get involved, lots of agencies, lots of referring out. The goal of children's services across the United States is to keep their kids with their biological families. So even if a kid's removed, the case plan is reunification. So that's the goal. Unless a parent terminates their parental rights. So, but then they said no thanks. If you're at Children's, you should know who your social workers are and how to contact them. It looks different in different divisions and it looks different in different places. Lindsay had a fun case by herself at Anderson on Friday. There's not social work at Anderson. Social services doesn't go to Anderson. We're not at Green. Every now and then you might see somebody walking around with a social work badge. They probably won't help you because they're there for like a very dedicated thing. So, there are 3 social workers in DWP. So we cover the DWP, we cover the 3rd floor. We are also the on-call service to the 4th and 5th floor. So if you're in speech or you're in OT or you're PT, and there's a kid you're seeing in session who's not a DWP kid who comes in and has a mark, mom has a black eye, domestic violence is child abuse. Mom has a black eye, says somebody did this to me. You should be calling Abby, Megan, and I. One of us will respond to you. And then if you're at a satellite, you page the multi-service team. And they just call you because they're not in your building. But they will triage with you. We've helped them cover satellite locations. Sometimes we're like, put us on speaker in your visit. Let us try to talk to the family or the child. We'll help you make a report. So if it was disclosed to you and we're not there, we will three-way call children's services with you. When they're mean to you, we'll help you try to ease through that. Contact us early. So like if you've got iffy, yucky feelings and you see this family like in treatment every week, like let us know so we can kind of help provide support about those interactions. If a child abuse report is made, there's specific documentation that we in social services must do. Technically, there's specific documentation that others are supposed to do. It seems less required. And then quickly, identity is this really lovely system where Hamilton County and Montgomery County, so Dayton, we can log in as social workers and see if a child is in the custody of children's services. We can see their placement. We can contact the foster parent from there. We know who the worker is, the worker supervisor, and the worker supervisor known as the chief, and get some information that way so we can figure out, yesterday it was like, so this random person just called in a refill of Risperdal, like who is this and how do I call them back? So I was able to figure out quickly, like, oh, they're in foster care. That's their foster mom. We should probably be talking to her. The Mayerson Center is not who you call in general if you're in clinic and have concern about abuse and neglect. The Mayerson Center is education and training for prevention of abuse and neglect. They do a lot of work with the hospital and the community. They have lots of informational pamphlets for families too about abuse. They conduct medical assessment and forensic interviews at the order of JFS and the police. So families cold call them. They typically don't get interviewed then. They have to be in communication with children's services or the police. And they are the forensic interview and child medical assessment for Hamilton County. Really, Hamilton County. Butler County has a different one. Claremont County has a different one. They have child advocacy centers in these different counties. Northern Kentucky has their own. So kids who get interviewed at Mayerson, it's not a simple, like we shouldn't be calling and paging Mayerson for an interview. Though our kids may be end up interviewed there after we have made reports and then children's services refers them in. If you come into the ED after like a sexual assault and there's the same nurse that is Mayerson, collection happens and the child would meet with the social worker there. So that was like a super quick, here's abuse and neglect, super happy, sorry session. Any questions about the process, the policy, abuse and neglect?
I think, just to like make sure I heard it right, did you say that like domestic violence counts as abuse or child abuse?
So domestic violence has to be reported if the children were present. It
Okay,
is child abuse if the child was present. So when mom says, but they didn't hear, we still report. The police are mandated reporters. These are clearly mandated reporters. They often forget to make their report. They go back, do their paperwork, and they don't call children's services. So we often still have to make that report. On the medical side of things, not OTPT speech world, on the medical side of things, there is an abuse screener that we do. It is 2 questions. I'm not going to get them right. It's something along like, do you feel safe to the child over the age of like 7 or some arbitrary number? Do you feel safe in your home? Has anyone ever touched you in a way that you didn't like? Well, that gets complicated. It's supposed to be geared towards sex abuse, but that gets complicated, get interesting answers. And then for the parent, it's, do you have any safety concerns for your child? The second one is, if you are in a relationship, do you feel safe in your relationship? So the way the parent answers those questions and the child, though I will be honest, in DWP, we rarely ask the child. In the rest of the hospital, the child gets asked that much more often. Depending on how they answer, it can be an a positive screen is an automatic social work referral. So even if mom's like, I didn't mean what I said, well, we come down and we talk about it, or but this was already investigated. Sometimes if I can't find that, I say, I'm sorry, I still have to report it to make sure it was already investigated. And when I call children's services, they usually are like, yeah, it's done, don't worry about it. But we still have to report it. Oh, we also have to report animal abuse now too. That's a new one. That one I haven't done yet, but if people are hurting their animals, we also have to report that.
Good question.
Animal
Does this
authority.
man know?
Yes, what are they called?
No, I was gonna. Child is hurting the animals. So I hear about that.
So technically now I think we have to report it.
Oh, no.
That comes up more often here, that the child's hurting the animals. Yeah, we used to have a case where I was like, you have to like get rid of the dogs. They gotta go. And that was pre this law, but that changed like a year ago. Now we have to report animal abuse to the animal authority. What is it called? Yes, thank you. I'm like, what is it called?
Animal authority.
And then there's,
I mean.
well, there's an. Yes, and then it's different in every place. But now it's also leaning towards, if someone's hurting animals to this extent, you probably should be calling children's services as well, because there's a lot of data that if you can hurt the animals, you're gonna hurt the people too. You had questions.
If someone makes a report, are they ever contacted?
You're supposed to be contacted. Technically, you should get it in writing. You should get a letter between them and then our mail system. That letter comes like way later. But you should receive a letter that it was determined to be closed, whatever the outcome was. It wasn't investigated, or it was investigated and your investigator's name is this and this is the person's number. But by the time you get the letter, that person's changed. There's a delay in the letters, but yes, you were supposed to hear back. In Ohio, Kentucky and Indiana are different. They're hard. Any other like questions? Yeah.
Formally inform, like the parent, the caregiver.
So in social services, yes. If I can, now sometimes I have people who have left who refuse to stay, those kinds of things, then I'll try to call them. Like, so just so you know, I'm gonna make a call. A lot of times we say, can we make the call together? And we can put it on speaker and make the call together. We tell, because they technically, the county won't give them our name, but they usually can figure out who it was. The only time that we won't tell, and then we don't, this is when Mayerson takes the lead and not us. If there's concern for medical child abuse, Munchausen by proxy, Mayerson takes over, reporting happens, nobody knows, it's not documented. It's complicated. That doesn't happen too often. But here, it happens very often in other areas of the hospital. But it doesn't happen that often over here. And that is not documented. Or told. Yeah.
ITT feedback.
Yeah, oh yeah, see, if you have abuse concerns, you should talk to me.
Okay, so we're gonna just talk about one other thing really quickly before we have the folks present on the two kids we're working with this semester. In ITT, there's team 1 and team 2. And the clinicians that are there and the non-clinical people will often have a supervisor or a LEND faculty member that will be helping to sort of coach them during the session. And so, like as an example, in physical therapy, Anna has Courtney. Courtney will sit next to her. She'll also do the evaluation with Anna. And my role would be as a faculty member, I'm actually watching all of the discussion, facilitating discussion along with Lindsay and Marta, but my job is to give feedback on your participation in ITT. So there are two different forms. There's forms for clinical folks and forms for non-clinical folks. Both of them are loaded to Canvas, and I want you guys to make sure to take a peek at them. Because at the end of the semester, you will have forgotten about this and you'll get an email from us that says, here's your feedback from the fall semester. It is a rubric. And so each of these sorts of behaviors has a score, I think of 0 to 2. And you can see what those mean on the form itself. And then there's opportunities for us to give you actual written feedback about your participation. I am also getting that feedback from your clinical supervisors. And so sort of taking all of that together, this is not a grade. There's nothing about this that's graded. And so sometimes if you see like a 1 in a category, the way that I would view that is, oh, I have room for growth in this area. And there's probably going to be a suggestion or two about how you could maybe grow in that area for the spring semester, right? We all benefit from feedback for growth. That's what this form is designed to do. It's about 4 pages long. Those of you that have a leadership role will also get feedback on your leadership role for that semester, okay? Anybody have a question about these forms? Here's the scoring rubric. So like on target, a number 2 is fantastic. That's what we want. For those of you who got straight A's and really want to get a 3, a 2 is fabulous. We're happy with a 2, okay? A 1 just means that it's a developing skill, right? It could be the first time you've had the opportunity to use that skill. And again, there's no grade associated with it, and the feedback forms on Canvas. Okay. All right, so let's go to the case presentations. And this is not a time they're going to do a PowerPoint, but I would ask whoever is for team 1 wants to get up and give information about that case. Yeah, perfect. Taylor, you get the mic. I'm gonna have you guys here. So, here you go. Yeah, so you're gonna be talking in front of each other all semester and next semester. No.
Okay, so for team 1, we're going to be evaluating Sincere Mokel. I don't know if I'm saying that correctly, but he is a 7-year-old African-American male. And one of the main concerns from his mom is that he might have autism. So that's why she's seeking out an evaluation. And basically she's had a lot of difficulty getting some services for him just because he doesn't have an autism diagnosis. So that's a pretty big motivator for her for why she's trying to get this evaluation completed. As far as like family, so he lives at home with his mom and his younger brother. He was enrolled in Latonia School District last year, but he was put in a mainstream classroom, even though he has like significant like developmental concerns. So he also has an IEP. So because of that setup, he wasn't getting a lot of the support that he needed. So that was a concern for mom. And he's also like generally, I'm gonna get to this later, but he's like a pretty medically complex kiddo. So he has a lot of like medical needs. So I think that presents a lot of barriers for this family. Previously, he attended a kids club, which is a medical, like a daycare for kids with complex medical needs. And it's also where mom works, which is interesting. And he recently like graduated out of that those services. So from what I can tell, there might be like some gaps in service he's not receiving. Anybody can feel free to correct me about that, but it seems like he's not getting a lot of the intervention that he was getting before, which was speech, occupational therapy, physical therapy. I think that's it. Like I said, he has an IEP. As far as like pre-academic skills, he can match colors and shapes. This kiddo's nonverbal. I'll get to that later, but I feel like it's important information to say right now. He's mainly nonverbal. Therapy wise, like I said, he was receiving PT, OT at Kids Club and speech. And he was referred for OT and PT back in April. I don't know where that stands. His chart's pretty intense, like as far as like encounters, and so it was kind of hard sifting through everything, but he was referred for those services. Let's see, where does it make sense to go now? As far as pregnancy, he was like significantly premature. He was born at 27 weeks. He also was 1 pound when he was born, so he was really, really tiny. Mom had some preeclampsia and didn't know it until like delivery, but no substance use, alcohol or medication during pregnancy. And then he was delivered by emergency C-section. So I feel like I might be going fast. Does anybody have questions or like, am I not clear? Carrie, what's up?
Who referred him?
He was referred by, I believe, his nurse practitioner.
Who is complex care? Okay. so
Yes.
primary
Yes. Good question. Anybody else?
care.
Okay. I can ramble sometimes, so I want to make sure I'm like not doing too much. Okay. Let's see. Like I said, he was diagnosed with global developmental delay. And then notably he started walking at age 3. So like pretty late for like some gross motor stuff. Again, nonverbal. He has a very, very long list of diagnoses, like medical diagnoses, which I'll list some. Bronchopulmonary dysplasia, which is a chronic lung disease for people who aren't familiar. And it typically happens at birth, like he's born with it. So it happened when he was like a newborn. He has congenital hypothyroidism. So he was born with thyroid issues, which he's on medication for. He was previously dependent on a tracheostomy, although that has resolved and he doesn't need that anymore. Dysphagia, which is like some swallowing difficulties, hypertension, and he had a G-tube, like a feeding tube, but that was removed by him in 2020. So in May of 2020, I guess he had enough of the G-tube and pulled it out. So what would you say? Yeah. We're good. So also he has a history of seizures. Although right now he hasn't had one for a while, and he was prescribed diazepam to control the seizures. Again, those seem to have kind of resolved and no issues there. He's had his adenoids and his tonsils removed. As far as like surgeries. Nonverbal, so jumping to communication, sorry, y'all, give you markers. So jumping to like communication, he's nonverbal. I was kind of confused in the chart about whether he used a communication device or not. It looked like at Kids Club, he used a device, but at school, he didn't have one. So I have some questions about that. As far as like receptive communication, he seems to respond to his name if it's like repeated. So it sounds like not the first time. If he's not interested, he's not having it. He knows how to respond to some words like no, and he knows like words like eat. It looks like he can say like some animal sounds, but like naming animals or naming things is difficult for him. He has some imitation skills. And nonverbal like gestures, like he can wave bye-bye and can say hi and bye. But it looks like he's mostly nonverbal, like not a whole lot of language. Questions about communication? Maddie.
Learn to try and do sign language with him since he's nonverbal.
That's a good question. I think we would have to wait and see like what language he has already. That's something we can ask like the parents if that's something that they've tried for sure.
How long ago was this trade from it?
Good question. I'm not for sure. Yeah. I'm sorry, I don't know. I don't. Thanks.
Like.
Yeah, I was.
Finding quick answers. is very
Isn't
hard.
that, yeah.
Me. You still didn't need the mic too.
How old is he now? 7. He is 7.
7.
Yeah.
I had a question that I wanted to bring up to our speech friends, just as a topic of conversation, because I know that kind of language has evolved over time and some advocates really prefer to say non-speaking instead of nonverbal. So just wanted to kind of have that conversation real quick. Leslie, I don't know if you want to.
For the trach removal that happened in April 2019. So Marta just found that for me.
Yeah, so nonverbal is a way that we probably most often use to describe people who are not talking. But when we use that term, if I said that to you, what are some preconceived, maybe some ideas that you might have about that individual? What would you think? They're not able to communicate at all, right? And so I like how Jen said non-speaking, or because then that gives us the idea that that person has things to say and that they have ideas to share and that they have ways to share those ideas that are not just verbal. So I'm glad that you brought that up, Jen.
Any other questions before we power through? No. Okay. So related to his social skills and like play skills, things like that. So generally he doesn't play with other kids. He can be around them, but it seems like his frustration tolerance for like others in his space playing is low. At least according to a note back in February. So maybe things have changed since then, but that's what I saw. So sharing is hard for him. He doesn't like peer interaction, but he does do like shared enjoyment. So like enjoying an activity with somebody else with like family members.
Called parallel play.
Pardon?
Called parallel play. So like you're playing just next to each other.
Oh, yeah. I didn't want to use terms that folks might not be familiar with. So I just wanted to like
Just referencing that as parallel play, like you're just playing alongside each other. You're not playing together.
Thanks, Carrie. Yeah, so social smiles is something that's been noted that he will do, but only, well, not social smiles, but only if you said like cheese, he'll smile, but like social smiles is not his thing. He does like give objects for like help, like if he were to request help, he does that. But not necessarily like giving you things to like enjoy an act or like share something with him or like enjoy an activity with him. So response to like joint attention. So like if I were looking at something and told him to look, he would like look at that thing. basically. He engages in pretend play, but it's self-directed. So kind of like what Carrie was saying, like pretend play, but like not with other kids. It's normally just with like by himself. Yeah, any questions or any contributions?
Any scripted play, like, where he, like.
Yeah, like repetitive, like echolate. Let's see. I may have wrote that down like in
I asked, if he, I'm just.
like repetitive
Yeah.
interest. Let me double check.
If he was just doing like a Toy Story. I follow this guy on TikTok who loves Buzz, and he does the Toy Story.
Yeah, just doing the same kind of.
So Lindsay used all her powers and found that he's not doing any like scripted like echolalia, but he is like requesting repetitive like shows over and over again. So yeah, does that answer your question? Okay, cool. I realize I need to like get to the end because I think Erica needs to present. Okay.
So you're good. I don't think.
What? Okay. Okay, so jumping down to like repetitive, I think that was a great segue. Repetitive behaviors, repetitive interests, sensory things. It seems that he's sensitive to textures, so he doesn't like soft or mushy things. Some loud noises bother him, specifically kids crying. Same. No. But he's not bothered by like bright lights or anything. So no sensory sensitivities related to light. He does have some repetitive play behavior. So like lining up toys or wanting things like a certain way when he plays. And then for repetitive body movements, I saw some like walking on his tippy toes and flapping his hands. And then I will jump to like behavioral and emotional concerns. So there were some notes about some tantruming behaviors. So like he would get mad like when his tablet dies, which would turn into like, they call them temper outbursts, which I thought was an interesting way to word that. But you know, things like crying, hitting, kicking, basically when he's refused something or is told no, that's when that happens.
Hard time with transitions too, then tantrums and like moving from one thing to the next. Does he have a hard transition? Sorry. I mean, I would assume, but.
Do you have the same note?
No. Tantrums are the same behavior then when people change.
Well, there wasn't a note about specifically transition, so that would be something that we would ask about for sure. Yeah. There are toys. There's some concerns for like overactivity. So he has a lot of energy for a kid of his age, like compared to another kid, another 7-year-old. Some attention concerns. So he's pretty distractible. Has a hard time sitting still for longer than 10 minutes at a time. But no like significant concerns for like impulsivity or like acting without thinking. So I thought that was interesting. He's not. Questions? What's up, Carrie?
No, you're moving on. As far as like the tantrums and the behaviors,
Mhm.
any idea of how long those typically last? Is that like?
Yeah.
Typically or?
No, so they're anywhere from 20 minutes to an hour. Yeah, so, and they're occurring multiple times a day, so. Good question, sorry, I glazed over that trying to be timely. And then I'll just jump to like adaptive skills. So things that I think are notable, he's not potty trained at the moment. And as far as feeding, no problems with eating. He seems to eat a variety of foods, fruits, vegetables, no like gagging or choking with feeding. Sleep seems okay, like not a big concern, going to bed at 9 PM, waking up at 7 AM. He previously had like constipation issues, but that has resolved, so he's not needing like Miralax or anything like that anymore. Yeah, I think that's him in a very, very small nutshell. Yeah. Ooh, I don't know. Yeah. it's not- Lindsay, you.
If you
use
don't,
your
just look at it,
skills.
can look at it later, but just.
A lot of imaging.
Sure, look.
Yes, please, help.
Sorry, I'm gonna bring it up again. It was from 2017, so he was young. His MRI. I think one of the more important findings they found, they had concerns for potential history of a prior preterm white matter injury. And other things that they found, they felt like were within normal limits.
Sorry, or.
They were. Yes. That's why I need the name. Yeah. That I know.
Very good.
Thank you.
Very much.
Thanks, guys.
One more, I'm sorry.
Oh,
Any
sorry.
other history on social, like mom, you said she was working at daycare, any other background on that?
Yeah, Janetta, I'm sure that was in there somewhere.
Time.
But what I,
She is off on some Tuesdays, but not every Tuesday, so this is the one where we're gonna see grandma too. Grandma,
perfect.
I think grandma is off of work every Tuesday.
Oh,
We
okay.
might see a lot of. But grandma's very heavily involved in his medical care and his day-to-day life, so she's got lots of information on it.
And we're gonna
Thank-
do all of this in the
Yeah.
nitty-gritty over the semester too. But you had a lot of information, sure, thanks for doing that.
Yeah, thanks, guys.
All right.
So for team 2, we're doing Vincent and is it Powell? Powell, okay, Powell. He is 6 years old and 2 months. And the main reason that he is coming for an evaluation is for possible autism. He's been working with OT here at Children's since he was 4, and his occupational therapist has some concerns about possible autism in addition to his mom having some concerns. So he was referred by his occupational therapist. Just to kind of start and go through some stuff, if anybody has any questions at all, why I'm going through things, raise your hand. I'll try my best to answer. He did not have as much in his chart other than like OT notes and some like care management things. So I might have missed something or it might not be there. So birth history wise, he was also premature, born at 33 weeks, and his mom also had preeclampsia. And he stayed at the NICU for 3 weeks, but they didn't really specify like what was going on there. So that's something I'll probably ask about a little bit. Developmental history wise, he was delayed in speech and also received therapy at school during like the preschool years for speech. Medical history wise, there's no vision or hearing concerns that were reported, and medical history, there wasn't really anything that was reported concerning. I believe, although it wasn't really stated explicitly, well, it might have been in a care note, that he resides with his mom and mom and dad are split. So he goes back and forth. One of the parents has 3 cats, and then he also has step siblings on his father's side. He used to attend East End Elementary School that's in the Wilmington School District, and he had an IEP for speech therapy. I tried to look in the chart and I didn't do IEP or the at all. I don't know. But he had one, and it was a smaller classroom, so there were about like 9 kids. So the teacher had a lot of concerns at that point that I'll get into in a little bit about what was going on with him that mom wasn't seeing at home. Now he is attending Holmes Elementary School, which is still in the Wilmington School District or Clinton County. And he still has that IEP for speech therapy. So since he still has that, we could probably ask and see if mom can get that for us. Regarding like behavior concerns, he doesn't have any like self-injurious behavior. He does have some disruptive behaviors, which is a lot of what the school is talking about. He yells and screams a lot due to different sensory processing things going on. So he does not like being in large crowds or being around loud noises. So in regards to like going to the gym with the rest of his class, he gets very upset and doesn't want to be there. There aren't really any like elopement concerns. Mom has reported that he is starting to be more bossy at home and wanting things to be a certain way. So that might be something we can investigate. And his teacher recently said that he is continuing to bring a stuffed animal to school, which he calls Yippee. And he's holding on to it the whole day. He was first referred to OT about a year ago, kind of a little bit over a year ago, back in March of 2022, for those sensory processing difficulties. Doesn't like the loud spaces like we talked about. And then there was also a slight delay in fine motor skills. He doesn't really have hand dominance yet. He likes to use his left hand, but sometimes he'll write with both hands, like put both hands on the pencil from what I read. He's also getting really picky about certain foods and certain like textures and refuses a lot of foods. And I'll share a little bit more about what he likes to eat. He was reevaluated back in March of 2023, and the school had a whole list of things that they thought was concerning for autism. He was overreacting to sudden and unexpected noises. He was scratching his face and picking his nails, had a limited diet, and was refusing a lot of foods that they were offering him. They said there were some sensory, like some things going on with like him liking touch and pressure, his hair being played with, getting big hugs from people. He really likes to put things in his line of vision when he's looking at objects. He was getting really anxious or stressed with new tasks. He was humming and singing to himself, struggling with waiting. He tends to like to be by himself and choose like solitary things. Regarding play, parents thought when he was younger, he was doing a little bit better with interacting with peers, but the older he's gotten, the more he kind of does like what Carrie was talking about, that parallel play, where he'll like build his Lego over here and a friend might build it over here. He also has preferred friends. So if another person comes in that he doesn't really prefer, he won't really interact with them and will get anxious. Feeding, like I said, he's been kind of picky. He likes pepperoni, chips, cereal, apples, strawberries, chicken nuggets. Does not like vegetables or pasta. And he's also been experiencing some difficulty eating in public places. Yeah.
When you're talking about his like play skills.
Yeah.
Doing
I'll see if I can answer.
you might. But when you're talking about his play skills, that he's like was reported he kind of used to play more with others and then kind of moved. Is like, were there any other signs of like regression almost, or is that just in play?
That's a great question. It's kind of hard to tell from based off of this. It really seemed like play based on like the OT reports that we have. I don't have any. Yeah, I don't have anything on communication, but that is definitely something I'd want to know because I don't know if you saw anything in there. I couldn't find anything about communication, and it makes me wonder too, like if his communication has like regressed at all. But it sounds like he used to play pretend and interact based on mom's report, and school is saying he doesn't do that at all now. Good question though. Definitely one to follow up on.
I think too, like, and we'll learn, there different people have different understandings of what pretend play is, looks like. So we can ask school and the family for that.
Yes. And also regarding play, it looks like he's not very flexible now in how he's playing. He likes to play with in a certain way with certain things. Really likes Legos. That was definitely in there. Let's see. For bathing, Mom says that he was having difficulty tolerating the sound of water running, but he's doing okay with that. Dressing, he does okay with undressing and dressing himself, struggling with the buttons a little bit. And he really does not like tags or collars. Hygiene wise, he does not like haircuts. He can't tolerate them. So mom's been kind of doing them, but it takes a while. And sometimes he'll run away when she tries to brush his hair. Other times he doesn't care. So it's kind of iffy. Toileting, there's no problems there, according to mom. And mobility wise, gross motor stuff he does great with. Yeah, and he's going to continue OT till October 27th. What questions do you guys have? Yeah. I'll see if I can answer them.
In skimming the file, it looks like someone at some point this year gave him a major depressive disorder diagnosis. Is there any more info?
I
on that?
didn't see that.
It looks like
so-
it was in March of this year.
Was it?
Chantel Thomas,
Give me a date, sorry.
3/9/23.
Who are you? I can't read the note. What is it? Is it here? It's a character where it says different, it's from a different,
Institution.
Behavioral health provider.
Okay.
External behavioral health, all we know about.
Based on the notes from Cincinnati Children's, they didn't say anything about that, but that's something we can look into also, because there's not a lot shared about like emotion regulation for him. And considering he screams and cries, I'm very curious about that. Yes.
You might not be able to answer this.
Okay.
You might be able to, but since he's already has an OT eval and is in OT, what would my role be then?
I don't know. the answer to that.
Okay.
Yeah, we'll figure it out.
We asked.
Okay.
She has an idea.
Okay, awesome.
His OT begged for him to be a Lent patient.
Oh,
Okay, so maybe we just need more.
Advocated hard and said, can you please take him? Mom is extremely motivated. She will get him there.
Okay.
So that we can still do it on paper though, right? Yeah.
I think.
And you're not gonna
it's not
bill-
gonna be charged.
It's not gonna be
so that's
charged,
not an
so,
issue,
good,
Right.
And he needs a more comprehensive assessment, but he may not have had the standardized testing you're going to do either, right?
yeah. then it's true.
Yeah, of course. Did you, Taylor, did you?
No, I don't.
I think there's back there.
Do we know what mom does for work and do we know their race?
Can you say that one more time?
I said, do we know their race and do we know what mom does for work?
There is a note in there that talks about work stuff. It was really long. I know she said she's employed, but she was also pretty blunt about some of the answers from what it seemed like. I don't know what she does specifically, unless. Oh, and then also says right now she's not employed. So that's a question we need to follow up on. Regarding race, I believe, based on the chart, it's white, but no. Based on the intake, they kind of just
Yeah, it's
do,
white, non.
yeah.
Does he has any history of ADHD?
They did not put anything from what I know, but that's something I was thinking about too, so.
Mom asked me about it when I called her to schedule, if you would look at that too.
Got it.
Like that means
everyone be quiet.
I'm kidding, I'm just kidding.
He has an IEP with school right now.
Yes.
And what's his qualifying,
we know that.
okay.
It was for speech, so I'm guessing it was some sort of language disorder, but they didn't say like what. Yeah. No, they didn't, we don't have the IEP, so that's something we can ask mom for. Harry, Maria,
Do we know how he communicates?
there was nothing in there, so you guys are gonna get to do a lot.
OT notes have some examples of
Yeah.
language that seem like he's asking and answering questions with full sentences.
And he's in school, so I'm assuming like they didn't note anything about communication, but again, that's an assumption.
Sorry, I was writing notes. So for behaviors, I have scream, cry, and attempt to like escape the situation. Any other behaviors that you found listed?
Not that they noted. That doesn't mean there might not be more. Picky eating, but I don't think it's anything that he's like, I'm gonna throw this up or anything.
I just want to compliment both Erica and Taylor.
You got all that information on it.
Yeah.
So
I was reading.
just a quick note,
ITT Team 1, the evals start on Tuesday, a week from today.
Yes. And Brad and I will be doing a lot of digging over the weekend and Monday into the medical record. There's a lot in there, so.
Yes, and his complex care team advocated for him to come. So they are open to talking to us. I might even invite his care manager to like a meeting so she can see it. So I will tomorrow send you the patient MRNs and full names. They'll be in your children's hospital emails. When it is children's patients, it's going to go to your children's hospital email. If I have to send it to external emails, I have to encrypt it. You have to create logins. It's a lot of work for both of us. So if you're gonna see these patients, you need to check your children's hospital emails. And I'll get you their names and MRNs tomorrow.
And that's where your ITT feedback will come as well, not there. So, if you don't have an application yet, you need to do that.
And let people know if you need help. I probably can't help you, but. Thank you.
Together.